We are coming towards the middle of week 4, but I did want to go over two highly missed concepts from last week. Um, Chain of infection, modes of transmission, and then levels of microbial control. Okay, because again, midterms is next week, and I want y'all to have as many resources as you possibly can as you're studying for your exams. So let's start over here, and we're going to simplify it. Okay, the chain of infection is how infection moves. Okay, I want you to think of it as a pathway. Something has it, it leaves, it travels, it enters, and then it infects. Our role is to kind of think about breaking that chain. So we have to ask ourselves, where can I interrupt this process? Is it hand hygiene, PPE, sterile technique? If you can stop transmission at any point, you protect the patient. We're trying to get to the interruption. Now, this one is about how clean is clean enough. Not everything needs to be sterile. So instead of thinking what kills everything, I want you to be thinking of what level is appropriate for this situation. There are levels, right? Cleaning is reducing, disinfection is killing most, sterilization is killing everything. But here's the key: the use of the item determines the level. So, is it entering into the body or just touching sterile tissue? That determines your answer. Not the product name, not the method, but the purpose. So let's bring it all together, okay? If we do not break the chain of infection, microorganisms spread. If you choose the wrong level of control, they aren't removed. So both concepts are really asking, how do I reduce risk to the patient? One is about stopping the spread altogether, and then the other one is about eliminating contamination. So on your midterm, do not rush. Pause, ask, what is this question really asking me? Is this about stopping the spread or choosing a level of control? If you slow down and think this way, your answers will improve. I promise. Okay. So I do have a practice question because, again, we are gearing up for midterms before we get into tonight's concepts. So a CST performs proper hand hygiene before and after patient contact. I want you to kind of ask yourself, what part of the chain of infection is being interrupted? Okay. If we don't break the chain at any place, what happens to our patients? What step in the chain involves movement from one place to another? Are we stopping the organism from leaving, from traveling, or entering? Taking the next step. When you see questions and you immediately, like, your eyes will be like, okay, I've heard this. Slow down. Pause just for a second. You're going to hear me say trust and verify a lot in module 3. So I'm going to start it here. You're trusting the process, but you're verifying with yourself, like, okay, what is this question really asking me? Okay. And notice what you're doing. We're asking, What is this question testing me on? This is how you slow down without running out of time. Because I know that's one of the bigger, you know, there's a clock. I understand. Okay. How does that sound? Thumbs up? Okay, perfect. All right. So for this evening, this week, we are not studying three separate chapters. I know it feels that way, but we're building one infection playbook. I want you to take a look at what's happening visually here. On one side, with chapter 6, how microbes live and grow. In the middle, with chapter 9, how they travel and invade. And then over here in chapter 7, how they change and adapt. Believe it or not, they are not independent facts. They are steps in a process. Now, if you only understood how microbes grow, but not how they invade or adapt, where would your understanding break down clinically? So, this is something I just want you to think about, okay? The gap is where infections win. When a patient develops an infection, it doesn't happen randomly. The organism survives, it finds some type of pathway, it actually adapts to pressure. That includes antibiotics and immune response. This is why microbiology is about patterns. As we get closer to midterms, instead of studying 6, 7, and 9 separately, I want you to ask yourself, how does growth support invasion? How does invasion create pressure to adapt? And how does adaptation change treatment and prevention? That's the deeper understanding. Microbes themselves succeed when we think in pieces, but we succeed when we think in patterns. If you understand where microbes thrive, you can often predict where it comes from and how it spreads. Let's look at the left. Microbes have a preference: temperature, oxygen levels, pH. Those preferences are not something that is random. Those are their survival requirements. So think about this. If a microbe prefers, let's say, moisture and moderate temperature, would you expect it to be found in dry metal air or in fluids? That instinct is microbial reasoning or microbiological reasoning. Now let's look over here. When you understand growth requirements, reservoirs start to make sense. Water droplets, soil, our medical instruments. Microbes don't choose these places, they're matched to them. Now, based on environment alone, which of these would you predict is the highest risk reservoir in our setting? The left or the right? What do you think? And I love this because what matters is how you reasoned it. So here's the connection. If a microbe survives well in moisture, we think about how is it likely to travel? contact, droplet, or instruments. Growth requirement shapes transmission routes. As CSTs, we don't just clean the instruments, we interrupt environmental matches. We're changing the temperature exposure, we're changing oxygen availability, we're changing moisture levels. And that's how infection prevention actually works. Microbes, they don't just spread randomly, they spread where the environment lets them win. With that, they also don't just live in environments, they change, they adapt, they survive them. A microbe doesn't need dozens of changes to gain an advantage. Sometimes just one genetic mutation is enough. So let's walk across the image together. On the left is biofilm formation, protection, and persistence. In the center, genetic change. It's the switch. And on the right, immune evasion. This is where they get in the host and they survive inside. Again, if you notice, not three topics, one survival strategy. Now let's take the guiding question seriously. If a bacterium undergoes a single genetic mutation, how could that help it form a biofilm? One small change could increase surface adhesion, meaning it's stickier to where it's trying to connect to, enhance the matrix production, so it's putting out a lot more product, improve communication with neighboring cells. This is where our logic comes in. Now, take that same mutation and think about our immune system. If a bacterium is harder to recognize or reach, how effective is the host's defense? Biofilm and immune evasion often work together. So not only do you have this protective shield, it's also able to bob and weave and evade the immune system. If a bacterium survives the immune response, what does that mean for infection duration? Acute or chronic? This is important because that distinction matters clinically. We will see the results. We'll see persistent infections. We'll see devices that are hard to sterilize. We'll see infections that do not respond as expected. And those outcomes often trace back to adaptation. One small genetic change can completely change the outcome of an infection. So we get to that single microbe, okay? It's rarely a danger. A massive coordinated population is, though. That idea changes how we think about infection risk. So let's walk through what you're actually seeing. You have one cell, many cells, and a dense coordinated population. This isn't just growth, this is organization. Okay? If one bacterium enters a surgical site, is the patient immediately infected? Yes or no? I ask that because the answer matters. But why matters more? The guiding question names three concepts that work together: generation time, horizontal gene transfer, and the virulence factors. Again, not separate facts. They are an escalation system. We start with generation time. If bacteria divide every 20 to 30 minutes, how quickly does one cell become thousands? Speed is the first advantage microbes have. Now, layer in horizontal gene transfer. This is where bacteria don't wait for generations. They're like, psh, they share the advantage. One cell gains resistance, another gains virulence, and suddenly the entire population is benefiting. Finally, we get to the virulence factor itself. These determine how much damage occurs, how easily the microbe spreads, how hard it is for the host to control the infection. This is where localized issues become systemic. So let's put it all together, okay? You got fast reproduction. You got shared genetic advantages. You've got increased ability to harm and evade. That's how a minor contamination can escalate into a severe body-wide infection. If escalation is the danger, what is the goal of infection prevention? Is it elimination of all microbes or interruption of escalation? That question reframes everything that we do. Now, as CSTs, we don't usually see the end stage. Our work is usually at the earliest point. We are preventing escalation if possible. Like that's where we're at, okay? That makes what we do, our role, incredibly powerful. Affection is not about one mistake. It's about how quickly small problems are allowed to grow. Does that make sense before we move on? Okay. So let's talk about a real clinical situation. Not a quiz question, but something that can happen. We have a facultative anaerobe in a deep, poorly oxygenated wound. Nothing about this is accidental. But let's start with what we already know. Facultative anaerobes can survive with or without oxygen. So, in a wound where oxygen is limited, does the population struggle or adapt? Right? It's going to adapt. In this environment, would you expect the bacterial population to decrease, remain stable, or increase, since I just mentioned that it would adapt? What do you think? And this is important because sometimes you may have a wound like this. Exactly. It's going to increase. The prediction comes straight from metabolic logic. We already know it's going to adapt, and we know from the last slide that one can go to 20 to 30, that becomes a whole population. Okay? In a deep, poorly oxygenated wound, they don't just survive. Unfortunately, it often thrives. The metabolic flexibility in action is what this is. So we add one variable. The microbe requires a new toxin gene through transduction from a bacteriophage. One event, one gene. That single genetic event can increase tissue damage, intensify inflammation, and overwhelm the host's defense, escalate a localized infection into a systemic threat. This is why genetics matters clinically. As CSTs, we may never know exactly which gene a microbe carries, but we do control wound environment, oxygen exposure, how we are handling the tissue, and our intervention times. Those factors determine whether microbes get the chance to escalate. And keep in mind that microbes don't need our permission to evolve. They just need the opportunity. Now, I want you to notice something important about this particular scenario. The pathogen hasn't become new. It's become possible in new places. Let's start on the left. Originally, this pathogen is transmitted through contaminated food. It requires body temperatures of 37 degrees Celsius to thrive. So, before the mutation, we look at the main risk. Now comes this pivot. A frame shift mutation occurs, and suddenly the microbe can grow efficiently at room temperature, 20 to 25 degrees Celsius. That is not a small change. Now look at the right side over here. We've moved from host-dependent growth to environmental persistence, and that completely changes transmission risk. When growth conditions change, reservoirs change. And when reservoirs change, infection control priorities must change. If a microbe can survive on surfaces at room temperature, then instrument handling, environmental cleaning, even our flow of traffic in the operating room and time outside sterile fields has to be adjusted. All takes on a new importance. If you were still thinking of this pathogen as foodborne only, what critical risks would you miss? I want you to be thinking about that because that's how assumptions cause exposure. I don't know if you remember that movie with Gwyneth Paltrow and Mark Wahlberg, Contamination? Was that the one where after the whole movie you found out it was from contaminated meat and the chef shook one person's hand and it spread globally, right? One interaction changed the trajectory of that infection. And had the chain of infection been broken by, instead of him just wiping his hand on the chef apron, just somebody washing their hands and just breaking that chain. Okay. And also think when microbes change what they can tolerate, they change where they can hide. Does that make sense? Make sure we're on. Okay. Now, I want you to remember a concept in patient safety is breaking that chain of infection, right? You hear me saying it a lot. Biofilms make that so incredibly difficult. Take a look at this image. This is not just a cluster of bacteria. It's a fortress. Let's talk about sterilization first, though. Sterilization methods are designed to penetrate surfaces, reach individual organisms, disrupt cellular function. But biofilm add a physical and chemical barrier. That matrix slows penetration, neutralizes agents, protects organisms deep inside. Now, think about this. If sterilization can't fully penetrate, which microbes survive? The outer ones or the inner ones? Which ones do you think? Yes, the ones that are buried deep inside. Now let's talk about that immune system. Phagocytic cells are very effective when they can reach their target. But biofilms hide surface markers, limit immune cell access, reduce recognition. So, what happens is the immune system can be present and still lose. Like it's there, but it can't recognize, it can't detect, it can't do its job. If both sterilization and immune cells are blocked, we have to think about what that means for infection persistence. That's why biofilm associated infections are often chronic. Let me repeat that. Biofilm associated infections are often chronic. Keep in mind that we are one of the last barriers before a biofilm ever forms. And what do I mean by that? Well, we look at how instruments are cleaned, how we inspect them, how we handle them, and most importantly, how they are stored. All of that determines whether microbes ever get the chance to build that fortress that you see on this slide. Now, we got to talk about a very common trap in micro. Many people learn growth and transmission as if they are two unrelated topics. But in reality, they are deeply connected. The concept on this particular slide, lysaging, is one of the most commonly missed ideas. And it's missed not because it's one of those like super hard or difficult, but because it's usually taught by itself, like it's an isolation. And if you've noticed from this particular course, everything actually builds onto each other and is interconnected. So let's walk through what you're seeing. We have our bacteriophage over here, and it's integrating its DNA into a bacterium. We get into the middle. The bacterium continues to live and divide and have its best life. On the right, that same bacterium now causes more damage. And if you notice, I'm trying to show you exactly where you find them in the chapter, okay? Or which chapter it's connected to, okay? The biggest thing to notice is that this is not a coincidence. This is a cause and effect. So let's think about this for a second. If viral DNA becomes part of a bacterium's chromosomes, does the DNA disappear when the bacteriums divide? No, it's copied and passed on. That means something very important. The bacterium does not just survive, now it's inheriting new traits. But here's the key connection. If this bacterium is transmitted, let's say through contact, surfaces, or even our instruments, right? It's not just being moved, it's delivering new genetic instructions into our patients. So we see unexpected severity. We see infections that escalate quickly. We see outcomes that don't necessarily match the original contamination. Leucinergy is one reason why. Transmission is not just about movement, it's about what moves with it. Now, I mentioned, I think, a couple maybe a live session before that I really like that they have clinical significance built in for us. So I want to kind of shift really quick to how microbes behave, to what happens when microbiology shows up in the operating room, because I feel like that's important. This is where our role as CSTs becomes real, real quick. So I want you to imagine this. You're in the middle of a procedure. The surgeon identifies a possible infection. At that moment, microbiology stops being a chapter, stops being words on a paper in a book, and becomes a decision point. In that moment, what matters more is it speed, accuracy, or communication? The answer is all three working together. When a surgeon requests what's called a culture and sensitivity, and we're gonna break that down a little bit later in this course, the goal isn't just to send a sample, okay? The goal is to get reliable information that will guide treatment for our patient that is on the table in that moment. If that sample is compromised for whatever reason, the results are compromised, and so is patient care. Now, think back to what you know about microbes, right? Some require oxygen, some are damaged by exposure, some grow slowly. So, how that specimen is handled matters. We're responsible for maintaining sterility, supporting correct collection, ensuring that when we've got permission to hand off that specimen, we do it immediately, communicating where the specimen came from. The surgeon will tell us, we write it and repeat it to our circulator. That information directly affects interpretation. A culture result isn't just a lab value. It's clinically significant only if it reflects what actually is happening in our patients. And that depends on what happens in the operating room with us. I want you to think about this. In microbiology, accuracy begins long before the lab. It begins with how the specimen is handled in the operating room. Okay, so let's do a little quick self check. Now, I want you, and this is for you kind of to work on your own as you guys are gearing up for this week. I want you to choose an organism from your reading. Okay, this is just for you. I'm not checking it. I just want to give you an additional resource to kind of help you gear up. Either Staphylococcus aureus or Escherichia coli, better known as E. coli. Okay, when you're looking these up and you're studying, I want you to imagine explaining it to a family member. Or if some of you guys are close, one pick the other, and explain it to each other from start to finish. Again, this is not a requirement. This is just an additional resource to kind of help gear you up. Because if you can explain it to where your classmate can understand it, you know it. Okay. And vice versa. And sometimes our peers can explain it in a way that hits more than us as even your professors. Okay. And it does a lot of things. It builds up your confidence and you're kind of networking with another member because keep in mind in module 4, you guys are in the lab together. The teamwork building starts here, continues in module 3, and then you guys are face to face in module 4. I want you to be thinking of how you're thinking as you're explaining it. Notice what you're naturally connecting, how it grows, how it changes genetically, how it improves or actually moves, not improves, how it moves from environment to host. Again, you're just integrating. And again, like I said, it's not a requirement, it's just another resource that could help you. If you don't have classmates' numbers here yet, family members, mom, dad, husband, wife, kids, if they'll listen. My little one does not ignores me, and the teenagers are like deuces. So, there's that. But if you have maybe your children or, will listen, okay? So now, if you got stuck in one part of the story, I want you to show yourself some grace, okay? That's just like a steady signal, like, okay, now I know where to focus just a little bit more on. I'm always going to tell you to show yourself some grace because this is a lot of information and we're changing how you're studying, not just in 210, but 200 as well. I feel like 210 is a little bit more, in my humble opinion, easier to kind of grasp a little bit because it is a lot of, okay, this is this is that. Versus 200, where we're stepping outside and it's more critical, it's more conceptual thinking. And we're going to get there in both. Trust and believe, okay? Now, the midterm isn't asking, can you list facts? It's asking, can you explain relationships here in micro? And that's exactly what we practiced this evening. So I'm asking you guys, which part of the story now feels the strongest for you? Growth, genetics, or how these little things are transmitted? The cool thing is that's where your confidence already lives. As CSTs, we don't necessarily encounter microbes as isolated facts, but we do encounter them as a process. Our job is to interrupt those processes. If you can tell the infection story clearly, whether you choose Staphylococcus aureus or Escherichia coli, you're already thinking like a microbiology professional. Granted, we're not microbiologists, but it's important for us to understand the microbiology behind it because of what we do to protect our patients. I want us to use this mindset as we're moving forward, where our role makes the biggest difference in a patient's lives. Now, I have something a little bit different because we are getting closer to the midterm. So let's see if it pops up for me. I've got to sign in really quick. Give me a second because we have a little bit of time. Let me see how many questions are on here. It's not that many questions. There are 20 questions, so we'll see. We'll see how much we get in. Okay. It's making me sign in 1 second, guys. All right. Here we go. Now, if you are able to join, please do. If not, you'll be able to see the questions and you can kind of type it into the chat. Okay. Game pin 334-3928. Again, we're only going to go as far as we can. If we get to all 20, awesome. If not, that's okay too. I will set a date for Kahoot so you guys can use it individually at your leisure. It only gives me 30 days to do it. So like today's April 20th. We may have until like May 28th or whatever, which is plenty enough time to have it for the midterm. Okay. So there are 13 of us. Again, if you are not able or if you can't log in right now, you'll still be able to see the questions, I think. It's been a while since I've done Kahoot. All right. So with the 8 of us, we're going to go ahead and start. Okay. Trying to see how many true and false I have on here. Don't think I have that many true and false. Think about us, our body temperatures. Mhm. What you'll notice is I've taken the concept here and asked it in a couple different ways. So you may only see 4 or 5 concepts out of these 20 questions. I also am making it so that, like, if you notice, this is pretty fast, right? True and false, I tried to make it 5 seconds, multiple choice 10, so that you are not second guessing. You're going with you're trusting yourself and you're answering. When I send you guys the link for the timed, I'll try to change this so that it's regular. Trusting your instincts, guys. Do blue or red. Blue or red. So if it's two, like if you're typing, you type in blue or red or square, circle, or yeah. I feel like I gave it by kind of like sliding over there. I think we have time for a couple more. Hmm. Biofilm. Remember, biofilm is that thick, sticky stuff, and we all have biofilm. It's on your teeth. You brush it off every morning and every evening. Keyword. I was gonna say the keyword. You guys already got it. Measuring. Good job. I think we have time for two more. Two more. I'm feeling good. I hope you guys' confidence is getting there. Like yes, because y'all are doing really well. Mutagen. All right. So there are 10 more. Like I said, I will get that Kahoot. I will put it, so you'll have the live archive section, and then it'll have the Kahoot link with all 20 questions. It will be available to like the later part of May. Yes, these are similar, not exact, similar to what you may see on your midterm. Again, remember the midterm is randomized, but um, same concepts, just ask a little bit differently. So, yes, yes, great question. Okay, we're still recognizing patterns. We have another resource that we have introducing Kahoot. Um, we are looking at how genetics accelerate risk, how transmission adapts when conditions change. Yes, the question is, will they be similar to what you see this week? Also, yes. So, yes and yes. We also looked at how transmission adapts when conditions change. So, for those of you that are watching the archive, and for those of you who are here, I want you to listen to the questions that I'm asking them. I didn't mention that before, but a lot of the questions I'm asking them to respond to, you may see concepts come up, exercise, knowledge checks, or even your quizzes. Okay. So, for those of you who are watching the archive, how might the AIMS test influence the development of new medical products and treatment protocols? How can we as CSTs use our knowledge of mutagens to enhance patient safety in the OR? And what steps can surgical teams take to minimize exposure to known mutagens like ethylene oxide and ionizing radiation? I really want to encourage you guys to continue to do what you're doing. You guys are asking phenomenal questions. Keep doing it. Stay curious. Um, you're working on the preparation. Some of you may feel like, oh, I'm not getting the scores that I want. Show yourself some grace. It will come. And when it connects, you're going to have that aha moment and the sky is the limit. Okay. As you guys are prepping for your midterm, which is next week, I will also let you guys know I'm going to be working on your professionalism scores as well for both courses. If you have not worked on that OSHA course, knock it out, get it out of the way so you don't have to worry about it. I haven't gone to that class yet to check, so I will be checking this week and kind of sending a little message if you have not, just as a reminder to kind of complete it before the module ends. Um, if a question comes up, let me know. Okay. I will be in office hours at 7:15 breaking down some more concepts. With that, I do want to wish you guys a wonderful evening, a productive rest of the week. I am sending positive vibes for this week for quizzes. I do want you to stay safe this weekend, and I look forward to seeing everyone who can attend next week live sessions. Good night, everybody.